Hello, my name is Victor Perez, and I will be talking about open inguinal hernia repair with mesh. So this is my first rotation, and I was in my surgery rotation. All right. So first, I'll talk about the patient. So for the initial assessment, the patient had a procedure on July 9th, 2025, from 12:10 p.m. to 5:01 p.m. He was a 42-year-old black male. The source was from a vascular clinic. They referred him to the GI clinic in regards to a large right bulge near the groin area. So for his HPI, Mr. NB, for HIPAA reasons, a 42-year-old male and a resident of Creedmoor presents to the general surgery clinic for evaluation of a right bulge in the groin area. He reports a progressively enlarging bulge in the right groin region that has been present for the past 8 months. He denies heavy lifting or straining. There are no specific aggravating or relieving factors identified. He describes the discomfort as a dull ache, localized to the right groin, no radiation reported. Discomfort is intermittent and mild to moderate in intensity and not debilitating. The bulge is present at all times with intermittent episodes of pain throughout the day. No relations to time of day and activity noted. So then his past medical history, he does have aggressive behavior. He does have bipolar 1 disorder, psychotic disorder. He is schizoaffective. He does have schizoaffective disorder, sexually acting out behavior of a childhood, and he does have some substance-induced disorder and trauma disorder. He has no known surgical history. Medications that he's on benzotropine, zero point 0.5 milligram tablet. He's on amantadine, 100 milligram capsule. He's on calcium vitamin D supplements. He's also on loxapine and metformin. And the only known allergies he has is peanuts. Social history. So he is a resident at the Creedmoor Psychiatric Center. He's a 41-year-old African American male, single and unemployed. Patient has a past psychiatric history of schizoaffective disorder and polysubstance use disorder, and outpatient drug treatment at the Genesis House, which is a supportive housing for him. He is a current smoker. He smokes 1 pack a day, about 3 times a week. He's not currently drinking, and he denies any IV drug abuse. So the review of system, constitutional, he has no weight changes, no fever, no chills, overall feeling okay. Cardiovascular, no chest pain, no palpitations, no discomfort when walking. Respiratory, no coughing or wheezing, no shortness of breath. GI, he does admit to some discomfort of the right groin area, denies nausea, vomiting, abdominal pain, diarrhea, constipation, appetite changes. Musculoskeletal, no myalgia, no joint pain, no back pain, no muscle weakness. Skin, denies irregular or new rashes, moles, color changes, or dry skin. Neurologic, no dizziness, lightheadedness, numbness, or headaches. Psych, no depression or no anxiety. Endocrine, no cold intolerance or heat intolerance, and no unusual hair loss or weight changes. Now we go to the physical exam. Physical exam, his vital signs, he's 97.97 degrees Fahrenheit. And as you can see here, all are within normal limits. Blood pressure is a little elevated, so he is hypertensive. General, he is well appearing, well nourished, no apparent distress. HEENT, Pearl, no icterus, moist mucous membranes, no oropharyngeal lesions, no temporal wasting. Thoracic and lungs, neck is supple, no mass, lungs are clear to auscultation, bilateral, no rales or wheezing. Abdominal exam showed a hernia is present in the right inguinal area, large and partially reducible, soft, non-tender, non-distended. GU, no dysuria, hematuria, or no flank pain. Extremities, warm and well perfused, no edema. Lymph, no cervical, submandibular, supraclavicular, axillary, inguinal lymphadenopathy. Neuro, he's the learn-oriented person, place, and date and time. Non-focal on exam. Now we go to the workup. So when we worked him up for surgery, pre-op, his BNP were within normal limits, CBC within normal limits, Type and screen, ABO grouping was O, he is Rh factor positive and antibody screen negative. So we test this just in case he does need a blood transfusion. So that's why we would test for type and screen. And BMP and CBC are just a protocol. And then we also did a CT abdomen and pelvis with contrast. He went and he got it, and it showed a right inguinal hernia partially imaged containing jejunal small bowel loop and descending colon. The cecum, ileocecal, and appendix not visible. Urinary bladder is unremarkable, and there was no pelvic or inguinal lymphadenopathy. Now, assessment. He's a 42-year-old male with an 8-month history of right groin bulge and intermittent discomfort consistent with an uncomplicated right inguinal hernia. The patient denies symptoms concerning incarceration or strangulation, such as nausea, vomiting, fever, or bowel changes. He has no history of precipitating factors like heavy lifting or straining. Clinical presentation suggests reducible non-emergent hernia requiring elective surgical repair. And now what the plan was. So the plan is to educate the patient on signs and symptoms of a hernia that becomes incarcerated or strangulated and advise to seek immediate medical attention if they occur. Surgery was scheduled on 7/9/25, and then pre-admission testing, physical exam and assessment, blood and urine test, electrocardiogram, x-ray, and interview with anesthesiologists. Patient will need to bowel prep with Galitelli on the day before surgery. Instructions given: Creedmoor to order prep. And then avoid activities that may increase intra-abdominal pressure like heavy lifting and straining until surgical repair. No physical therapy indicated at this time. So now I'll start to introduce what an open inguinal hernia is. So the epidemiology, inguinal hernias are very common surgical conditions, particularly among men. While some are congenital, most adults' inguinal hernias are acquired. Inguinal hernias are the most common type of abdominal wall hernia. In the sex ratio, they're more common in males than females, ranging from 6:1 to 9:1. And then the median age of diagnosis is between 40 and 59. Now we'll talk about like etiology and risk factors. So the congenital factors, it's usually patent process vaginalis, which are particularly more common in inguinal hernias, particularly in indirect ones, can be linked to persistent opening in the process vaginalis, the pathway through while the testicles descend during fetal development. If this opening doesn't close properly, it can create a weak point in the abdominal wall that later develops into a hernia. Weak abdominal muscles. Some individuals are born with inherent weakness in their abdominal muscles, making them more susceptible to inguinal hernias. Now, acquired factors. Age. As people age, abdominal muscles can weaken, increasing the risk of hernia development. Increased abdominal pressure. Activities and conditions that increase pressure inside the abdomen can contribute to hernia formation, like chronic cough, constipation, straining, heavy lifting, obesity, pregnancy. And then another acquired factor is connective tissue disorders such as Ehlers-Danlos syndrome and Marfan syndrome. And then other contributing factors are family history, being a male, being more prominent, and then premature birth. Now, the pathophysiology. So we have to distinguish the two types of inguinal hernias, either direct or indirect. So direct hernias develop over time due to weakening of the transverse fascia within the Hesselbach triangle, a region in the lower abdominal wall. This weakening can be caused by factors like age, strain, or injury. So here, the hernia protrudes directly through the posterior wall of the inguinal canal, and I'll show you a picture on the next slide, but which is medial to the inferior epigastric vessel. More common in older men, direct hernias are often associated with chronic strain on the abdominal wall from activities like heavy lifting or persistent coughing. Now, indirect hernias are typically congenital, meaning they are present at birth. They occur when process vaginalis, the peritoneal sac that normally closes during fetal development, fails to do so. This leaves an opening through the abdominal content, which can protrude. The hernia follows the path of the sphenoid cord in males or the round ligament in females, transversing the internal inguinal ring and potentially extending down into the scrotum. This is most commonly seen in infants and children, especially premature babies, due to incomplete closure of the process vaginalis. Now here I just want to show the Hesselbach triangle. So here you can see how right here. I don't know if you can see my mouse, but here, which is the medial aspect, is the rectus abdominis muscle. Here being the lateral aspect, which is the inferior epigastric vessel, and here being the inferior part of the triangle, which is the inguinal ligament. So when looking at this Hasselbeck triangle, you can easily distinguish between direct or indirect. Like they said that for inguinal, it's usually within the triangle where the hernia protrudes, so that can help you distinguish between direct and indirect. While indirect inguinal hernias are usually lateral to the inferior epigastric vessel, which helps you distinguish between indirect and direct, as I was saying. So here's another picture, which really does show the direct being in the triangle, while indirect usually is onto the side and then goes down to in men, usually down to the scrotum area. Now, clinical manifestation, it's usually a visible bulge, a bulge in the groin, often more noticeable when standing, coughing, or straining. These are the hallmark symptoms. You can also have pain and discomfort, like aching or burning sensation in the groin, exacerbated by physical activity. You can feel like a heavy or dragging sensation, so that's like pressure or heaviness in the groin area. In men, you can see scrotal swelling sometimes, which is seen, which can cause some discomfort. And then also for these types of hernias, it's worsened with activity and becomes more pronounced. Um, and then pain relief with rest. If it improves while lying down, that can be another sign. And then nausea and vomiting is a sign of incarcerated or strangulated hernia. So just be careful of the signs when explaining to your patient about the possible manifestation when it leads to that point. Now the workup, again, we would do a CBC to assess kidney, liver, and blood sugar function, a UA to help rule out urinary tract infections or kidney disease, ECG test assess heart rhythm function prior to surgery just to make sure that everything looks okay. And then the initial test for hernias is usually a physical exam. Usually you're able to visually inspect and palpate the affected area. And then while doing so, you would ask the patient to either cough or strain to make the hernia more prominent. And that would typically be enough to make a diagnosis. But for surgical purposes, you would do a CT scan with IV contrast, which is the best test to help locating the exact spots of the hernia and know where to expect the incision lines. So management, there's always surgical management and non-surgical management. You would always obviously try the non-surgical management, but I'll first talk about the surgical management here. What you would do is either an open inguinal repair, which involves surgical incision in the groin area to assess the repair of the hernia. I'll go more in detail on the following slide. And then another option is a minimally invasive inguinal hernia. This utilizes small incisions and a camera with specialized instruments, usually robotic instruments, that often helps in a less post-op pain and faster recovery. And sometimes you would do a mesh placement, which is just a synthetic mesh used to strengthen the abdominal wall and reduce the risk of recurrence. Now, in non-surgical management, you can do watchful waiting if the patient's asymptomatic or minimally symptomatic hernias. Monitor for changes and address symptoms that may arise, like strangulation or like strangulation. And then supportive truss. A truss may be recommended to provide some relief with symptoms and prevents the hernia protruding, but it's crucial to ensure a proper fit and usage. This is kind of like to reduce the swelling of the hernia and put it back in place per se. But again, it's also not commonly used just because you have to make sure that it's properly fitted. So now we'll be talking about the open laparotomy inguinal hernia repair with mesh. This is a procedure we did for this patient, and it's just a surgical procedure where a surgeon makes an incision to assess and repair a hernia in the groin area. The hernia is pushed back into place, and a piece of mesh is inserted to reinforce the weakened abdominal wall. So first you would make an opening approach, a single incision to the groin area, And we would use laparoscope, which is just like a camera, to help us pretty much assess inside and be able to see what we're doing. We would also use mesh reinforcement, a piece of surgical mesh. We did use mesh to strengthen the abdominal wall and make sure that reoccurrence doesn't occur. It can these meshes can either be absorbable or non-absorbable. We use an absorbable mesh. And then with when we opened up the patient, we reduced the hernia content. So what we did is we pushed it back in and then tried to remove the this in this case it was an indirect hernia. So we removed it from the scrotosac. We looked for this sac specifically responsible for the hernia, and then we used it and pushed it back where it was supposed to be. And then fixation of the mesh, we sewed the mesh in place to make sure that it, like I said, to stay in place. And then closure, we closed the incision with sutures and dressings were applied. There are advantages and disadvantages to open laparotomy. An advantage is it reduces the recurrence rate, tension-free repair, and there's proven effectiveness. A disadvantage, though, is there is a higher risk of infection. Mesh can migrate. There is some chronic pain and possible longer recovery time compared to laparoscopic techniques, which include robotics. And then for complications, you can get a seroma hematoma, you can get urinary retention, surgical site infection, injury to blood vessels, chronic groin pain, nerve injury, and mesh migration. And yeah, that was my presentation. Thank you. And I hope you enjoyed this presentation on the open inguinal hernia repair with mesh.